Hi guys, welcome back to the channel. I'm Dr. Downey, and as promised in the previous video, this is a follow-up video on using MENT as TRT, or replacing testosterone with MENT or Trestolone. So, in this video I'm going to introduce you to a possible protocol based off of research to achieve the most selectiveness and most benefit from using MENT instead of testosterone. I'm not suggesting you use this protocol, but you could discuss it with your doctor if you are not responding favorably to testosterone and would prefer a more selective drug. So, as mentioned previously, the reason why MENT is being looked at for possible TRT or replacing testosterone is because it is more selective. And at the same time, it's able to maintain sexual function that testosterone does and convert to estrogen. So essentially you have all of your hormones in check. Whilst it does suppress testosterone like other compounds, it still maintains that sexual function, which makes it more beneficial than using, let's say, a dianabol, which will suppress you and keep your estrogen in check but won't maintain your sexual function. So if you want to learn about the pharmacokinetics with regards to MENT, you can find that in other videos, or the previous video actually I mentioned it, but let's go through research and come up with a protocol a protocol that you could use for TRT. So in terms of maintaining mood, there is evidence to suggest that, and that is shown in this study here. Most of these studies were done using implants, but I think we can still take the implant and calculate a daily dose, which could be useful. So in this study, the implant released about 700 to 800 micrograms of Trestolone daily, which is 0.7 to 0.8 milligrams daily, and this was able to maintain their mood and sexual function. So this meant their libido was fine, they had a good waking erection, they had strong erections, etc. And this was able to maintain the sexual function as much as 67 milligrams of testosterone enanthate a week would. In this case, they compared it to 200 milligrams every 3 weeks of testosterone enanthate. So it was able to maintain sexual function in that regard, and they had similar results. The reason this study was interesting is because it showed that 5-alpha reduction, because Trestolone is so selective, it isn't reduced by, well, not because it's selective, but because it's a 19-nor testosterone, it's not reduced by 5-alpha reductase to DHT, and that proves that DHT isn't really useful for sexual, or needed for sexual function, and this makes you wonder why finasteride would decrease sexual interest and sexual function, since that decreases DHT, and that's the mechanism behind it. Well, it's thought that that's how it decreases your libido, but at the same time, Trestolone maintains your libido whilst not being converted to DHT. So that's another theory behind why it's so selective and doesn't induce hypertrophy of the prostate. Remember, if you're going to use Trestolone, it's an acetate ester and you'd have to inject daily. That's just a side note. So in the study, they did say that it restored libido, just like testosterone, but what was interesting is MENT, those using MENT seem to report less aggression and aggressive behavior than testosterone did. And this can be seen as a positive or a negative, depending on the type of person. For me, that would be a positive. So what doses are most researched and or are closest to TRT? So if we look at the previous study, it said 700 to 800 micrograms, or 0.7 to 0.8 milligrams daily seems to replicate that of TRT. But let's look at another study where they compared the same dose to 400 micrograms, or 0.4 milligrams daily, And as you see in this study, it showed that 400 micrograms, whilst it was able to maintain lean tissue to an extent, it was sub-physiological because it failed to maintain sexual behavior and sexual function and erectile function. So this would indicate that it was it wasn't being used at the correct dose, and they found that 2 implants daily or 800 micrograms daily, as suggested in the other study, maintained sexual behavior and erectile function. So this would suggest that 750 to 800 micrograms is a better or a better dose to use. And then let's look at another study which was done on rats, so it's not as good as the previous 2 studies. And in this study, they showed that a dose of 36 micrograms a day in rats induced prostate hypertrophy. So the aim of using MENT is to be as selective as possible, so this dose anything under this dose would be better to use because it shows that after this dose it's not as selective as it usually is. So 36 micrograms a day in rats, if you convert that, is approximately 10 micrograms per kg per day in humans, which, so for a 100 kg individual, this would equate to about 1,000 micrograms daily or 1 milligram daily. And this suggests that that might be too much if you are looking for the selectiveness of this compound. So therefore, this again supports 800 to 750 being more favorable. And at these doses, this concerns a lot of people because TRT is sometimes about aesthetics, especially in those struggling to lose weight in stubborn areas because they don't have optimal hormone or they don't have hormonal optimization. And they found that these studies and these doses, especially the 800 microgram dose, that there was favorable body composition changes. So what that meant was they were able to maintain lean mass and drop fat mass simultaneously, which is commonly seen when using TRT, so it just shows that this was able to replicate that. So let's look at biomarkers and health markers and see what you should expect on Trestolone. So there are other studies that I excluded from this one, which I mentioned in the previous video, that were done in Finland and Chile. The reason I excluded them is because we've already selected a dose for TRT, and those studies used doses much higher. So we're just going to not include those in this video. So in terms of hematological markers, this has been one of the main reasons I've seen people want to do MENT-only TRT instead of traditional TRT, because on traditional TRT your hemoglobin and hematocrit raise. However, it was noted that at 800 micrograms, there were no changes to the hematological markers, and even in the studies using higher doses, they didn't notice any change to hemoglobin or hematocrit. Again, the prostate didn't decrease in size. It did in the 400 microgram group, but it didn't change in size, which is good. And the PSA actually decreased. I'm not a big fan of PSA as an indicator of prostate activity, but it just indicates it was prostate sparing to an extent. So your lipids, they didn't notice any significant change to LDL, total cholesterol, or HDL, surprisingly. However, at higher doses in the previous studies, they did notice changes, which shouldn't be of concern if you're using these replacement doses, but just as a precautionary measure, lifestyle measures should be in place and in combination with routine testing for changes in your cholesterol. So lifestyle measures include low intensity steady state cardio, eating a healthy diet with low saturated fats, eating a lot of fiber, etc. And in terms of liver markers, there were no changes. However, at higher doses, it has been noted that there are changes, so it's important to monitor your liver function whilst using this drug. But the effect on liver function could be transient, like with most injectable steroids. So there was an issue, however, with these doses, and it was noted even at high doses that bone turnover is decreased, as well as, which obviously means that bone mineral density decreases. And this could be partly due to the selectivity of the drug, but obviously they're not sure why this is the case. They just noted there was a decrease in bone mineral density, which is a problem because it could lead to condition fractures or osteoporosis. So it would therefore be advisable to take vitamin D and calcium as preventative measures, and just include weight training, because weight training, especially squats, have been shown to decrease, or well, they are just favorable in terms of increasing bone mineral density. So, and you just need to be aware of the risks to the risk of stress fractures. And again, try limit using anti-estrogens, because at this dose estrogen shouldn't be a problem, and anti-estrogens do also lead to a decline in bone mineral density. So based off of all this research, what is the protocol? And it's fairly simple. Obviously, first consult with your doctor, but the protocol would consist of daily injections of Trestolone acetate at a dose of 800 to 750 micrograms daily. I haven't done a weight recommendation because I didn't really include weights in the study, and these doses have been studied the most, so that's just the recommendation. So 800 to 750, or 750 to 800 micrograms, or 0.8 milligrams, or 0.75 milligrams daily. You could start at a lower dose, such as 0.4 milligrams or 400 micrograms daily, and then titrate up to effect. Since it's such a short acting ester, you should be able to notice the effects quickly and see which dose suits you the most. And then as preventative measures, I would take 1,000 to 2,000 IUs of vitamin D daily, or at least 5 times a week, whilst you could supplement calcium or just eat a diet rich in calcium, and pair that with weight training. So in terms of blood test, I would do blood tests after 1 month. Hormonal profiling is a bit pointless in this case because you can't pick up Trestolone unless you specifically ask for it, or the methyl estradiol that it converts to. So if you look at your estrogen, it will be low, but it won't be indicative of your actual estrogen. So it's a bit pointless. You'll just see that you're shut down, which is expected. So instead, I'd get a full blood count, or full blood panel to look at your hemoglobin, hematocrit, your liver function tests, your urea and electrolytes to ensure your kidney function is not taking a hit, and your lipid panel. And if there is anything wrong with those, I would suggest you either decrease or swap back to TRT, or typical traditional TRT, or consult with your doctor. But if everything's fine, you should continue doing blood panels or blood checks at least 3 times a year when you're on this. So I hope that video was informative, and that it taught you something. If there is anything you'd like to know, please feel free to comment below. If you like the video, please like it, subscribe, and yeah, I'll see you in the next video. Thank you.